Okay, welcome everyone. My name is Kara Kaikini. I use she, her, hers pronouns, and I'm the Executive Director of the Maine State Breastfeeding Coalition. Before we get started with the webinar, I want to make a few announcements. One is to let you know that this is being recorded and will be available on our YouTube page, where we have our previous webinars and our previous meetings recorded and put up as well. So know that you can find those there. We are not able to offer continuing education units at this time, but we can send you a certificate of attendance if that is helpful. We'll be sending you an evaluation after the webinar, and if you would like a certificate of attendance, then be sure to add your email at the end of that evaluation, and we will send that over to you. Okay, we also want to let you know what we have coming up. Our next webinar on June 5th will be about extended nursing and weaning and strategies for working with families. In August, we'll have a webinar about social determinants of health and how it's related to the population we're working with. In October, we will have a webinar about functional oral evaluation of the dyad. And we hope to have Dr. Soliman back on December 4th to talk about the trends of dieting systems and breastfeeding. So we really look forward to this series this year, and we'll have some other registration options for you soon. You might be able to have the option to purchase a bundle so you can just have all of the webinars paid for ahead of time and have tickets available ahead. So we'll be sending more information about that as time goes on. And thank you for registering or for making a donation of any amount that you were able to do. We really appreciate that. We welcome donations at any time, and you can find ways to do that through our website or through these QR codes. And we also welcome donations of time. And if you are interested in volunteering, that you can let us know through those same websites and QR code as well. And there will be also a link in the evaluation we send you if you are interested in volunteering. We can use all the help we can get in so many areas. So thank you so much. And we want to welcome our speaker, Dr. Soliman. And Dr. Soliman, I believe that you have an introduction in your slides. I'll actually let you introduce yourself because for some reason my notes are not here right in front of me in this version. So I'll let you go ahead and introduce yourself and start sharing your screen, and we'll go from there. Really appreciate
Yes.
Dr. Soliman being here today.
Okay. I will start sharing my slides.
Yes. Let me know if you need me to give you, okay, great. And if you haven't yet introduced yourself in the chat box, please do that. It's really great to see where everyone is calling in from. I know we had people registering from around the country and around the world, and they might be watching the recording right now. So thank you for joining us through the recording. Otherwise, it's great to see. It looks like we have a lot of Maine folks here today, and I always love to see that too. So thanks for being here.
So I will start introducing myself briefly. I'm a pediatrician and neonatologist. I'm an IBCLC since the year 2008. I'm happy to be still an active IBCLC. I have been volunteered in several international organizations that support maternity and child health care. I'm a board member of the directors of the MILCC, which is always supporting the mission of the IBCLCs all over the world. So I will not take a lot in introducing myself because what means for me is the scientific information we will talk about today or the skill we are emphasizing on, which is really important for every IBCLC because I know that it doesn't include only the title which is in front of us, which is moving from exclusive pumping and bottle feed to direct breastfeeding, but we will talk inside this presentation about what the skills that needs to be with each IBCLC when you are relactating, when the mother is relactating, when a mother introduced the bottle at certain time and needs to be back. Also, we have the induced lactation. Actually, it is some sort of the same strategies when you are moving from the bottle feed to direct breastfeeding. So this is involved in, a side way in the presentation. We are moving today to through the different aspects of this strategy, and this skill is very essential for every IBCLC or every healthcare provider who is dealing with the mother and the breastfeeding diet. So the objectives, the participant will be able to develop the importance and the consolidated understanding of the importance of the exclusive pumping to keep a line of transition back to breastfeeding, the hazards of using the bottle to give pumped breast milk, and the importance of as soon as possible of the transition to direct breastfeeding if the mother is willing to return back to direct breastfeeding. So the outline we will be moving through is the definition and indications of the exclusive pumping and how the exclusive pumping support the milk supply. Why do we instruct the mother to be dependent on the pumping? What are the main instructions that you should guide the mother to keep up her milk supply? The requirements for exclusive pumping, how bottle feeds impairs the direct breastfeeding, and the strategies to go direct breastfeeding for the other alternatives, expecting that the mother use any other alternative other than the bottle. The indicators to stop pumping, to shift totally to direct breastfeeding, and then we will have a quick picture of a mother who was telling her experience returning to the direct breastfeeding from exclusive pumping. So what is this exclusive pumping term means? Some families choose to exclusively pump the breast milk and to continue using the pump without direct breastfeeding. And when we talk about this, there are a lot of reasons. So let us all first define what is the exclusive pumping, because in the last 10 years, there have been a growing proportion of families who just need or took that decision that they will depend only on expressing breast milk, either through the direct expression, which I know is difficult to be exclusively the way, or through the aid of the pump. And the prevalence of exclusive pumping, according to the studies which is present in Asian countries among families choosing to breastfeed, it's from 5.1 to 19.8. And in America, it was, according to studies which I found on the PubMed, from 5.6 to 14.3. So this is in the first 6 months. However, in different countries, I didn't find rough results or results that could be documented. This means that maybe it is underestimated. The value of exclusive pumping may be underestimated because not everything that can be essential is donated in the studies, because as you know, everyone who is working breastfeeding medicine, we know that we depend on ourselves to support the breastfeeding. We have no donations, we have no foundations that support us financially, because it's mostly volunteering work. So when we talk that it is a few rates that is documented about exclusive pumping, this doesn't underestimate the percentage of families who depends on exclusive pumping. Exclusive pumping is defined as a process of expressing breast milk several times a day, then feeding it to the baby directly. And then feeding to the baby, usually when you assess how the mother gives the expressed breast milk or the pumped breast milk, even if they start with the other modules that we know as the cup feeding, as the spoon feeding, as the SNS, they never depends on that to the end. It's a maximum from my experience in my clinic. Even it's a maximum that they can use the syringe, or the difficulty of the cup feeding, or the difficulty that the mothers assume about the cup feeding is not very common to be used for feeding the expressed breast milk. However, the syringe is a trial among a lot of mothers. But when you talk to these mothers, they say that usually they depend on the syringe for at least maybe the maximum is 4 weeks, and then they shift it to the bottle. So mostly exclusive pumping ends by bottle feeding. Whatever the module that the mothers start with, they usually shift to the bottle for the ease and for the difficulty of continuation and lack of support they have during this journey. Direct breastfeeding, however, is defined as the infant receiving the breast milk from directly attaching to the mother's breast, with or without supplementation of pumped breast milk or even artificial formula in cases of low milk supply. So what are the indications of exclusive pumping? If pumping have started when an infant was hospitalized in the NICU, this is a very common cause that the mother continues exclusive pumping, especially when the baby returns back to her. No one guides her about the importance of keeping up her milk supply, or actually in the NICU, when the mother is shifted, when the baby returns to the mother, usually he is fed in the NICU also by the bottle. So she finds a large difficulty to feed the baby directly on the breast. And this is a main struggle that we should change as healthcare providers. So the mothers whose infant is admitted to the NICU must be trained how to breastfeed the baby with the SNS, how to finger feed to stimulate the suckling. The nurse should be trained not to give the bottle to the babies which are admitted in the NICU, to give a way back to direct breastfeeding. And this is a main struggle that we found as neonatologists. When you are a neonatologist who is an IBCLC or a breastfeeding consultant, you know what happens in the different NICUs all over the world. There is no strategy to support that this infant will return back to breastfeeding. They give the bottle, the baby usually is on fluids, IV fluids, and then after shifting from the IV fluids to direct breastfeeding, we have a struggle. The nurses never try to train the baby for the infant suckling or to introduce a way like SNS or finger feeding to keep away for the mother back to direct breastfeeding. Also, one of the things that can be also applied in the NICUs, to have the mother beside the baby. And according to what happened in different NICUs, I have an experience with a hospital that applied this strategy in Egypt. It was in Alexandria, a city in Egypt. They tried to make a room for the mother beside her babies who are admitted in the NICU. And they found that this saves a lot of money. The result was earlier discharge for these infants, healthier infants, and also lower incidence of morbidities among these neonates. So this means that there are a lot to be changed also in the strategy. If pumping may have been proposed as possible short-term solution following problems with direct breastfeeding, especially when the mother has difficulty with the latch, especially when the mother have difficulty to understand what are the hunger cues of the baby. Mothers need or want to monitor the intake. Mothers who are still worried about the intake of their babies, especially if the baby have a struggle with gaining weight in the first 2 or 3 weeks, or have passed into deep jaunts and was admitted for phototherapy or something like that. So this makes the mother lose confidence about her own self, that she can directly breastfeed this baby. So what happens at this stage? She feel relieved when she pump her breast milk and see the amount in front of her eyes, especially mothers who suffer from postpartum depression. They pass unnoticed. No one feels how the mother struggles with her thoughts, especially new mothers. And when we talk about new mothers, we will add for this category the young mothers. Young mothers have struggles who no one understands what they are suffering. She feels that I'm not sufficient for the baby, I will not satisfy him, especially with the common misconceptions which is told to the mother from the surrounding or from the first degree relationship, like the husband, like her own mother, and like her mother-in-law. They usually tell her, your milk is not enough. So she have trauma. And when this is not cured with the efficient IBCLC or lactation consultant, it will end the best result that you can have from this is that the mother would like to exclusive pump or to express her breast milk to get relieved about the amount that the baby takes. And when we talk about this point also, I'd like to talk in details about this, because some mothers usually try to express in a faulty way. So one of the main things that should be taught to the mother during antenatal period is the way of hand expression. Because when I see mothers in the clinic in the first 2 weeks postpartum, they usually have the concept that they have no breast milk. Why do you assume this? Because of the quantity, because of the faulty expression. She is assuming that the colostrum is about maybe when you have a pediatrician to instruct who is not related to breastfeeding medicine and is instructing the mother to feed her baby either breast milk or formula. They tell usually the mother feed him every 2 to 3 hours about 30 milli, and the whole size of the stomach cannot afford this every feed. So the amount of colostrum is far beyond this. It's from 5 to 7 milli per feed, reaching 38 to 40 milli depending on it is male or female baby. So it's far beyond what the mother assume or the conceptions that is present among healthcare provider before the community members and the families. This is one point. The other point, when a mother tells me that she have no milk supply and we start expressing in the clinic with her own consent, we find that she have a gush. She is, there is a fountain of breast milk in my face. This is what she have already in front of me. But she insists that when she tried expressing, she have just one drop and it stopped. And you ask her to express or to show me how she expresses her breast milk the way she uses in home. So I find that she are starting to squeeze the nipple, squeezing the best one which can express her breast milk the most corrective way is in the middle of the areola. And as healthcare providers who understand breastfeeding medicine, why do we study the anatomy? Because you need to know where are the milk ducts located. You are dealing with a structure. When a surgeon go into a surgery, he must understand the anatomy. It is the same idea for us as healthcare providers who are involved in breastfeeding medicine. We understand the anatomy to know where the ducts are placed, where are the most stimulus that can lead to expression of breast milk. So the ducts are present according to the anatomy in a circle of 30 millimeter away from the areola. So she must places her fingers at least half an inch from the end of her areola, and this depends. We are talking about the moderate size, so if it is extra large, she will be at least maybe 3/4 of the size of the areola and put her fingers in the 12 and 6 o'clock positions, or inverted U shape and the 3 and 9. So it must be taught for the mother. It is an experienced skill. Even the healthcare provider should know this. So faulty expression can lead her to the assumption that she doesn't have breast milk. Using a faulty pump, no one guided her about how to choose the proper pump. This is very essential, because when you choose the proper pump, you know how to maximize your milk production. Most of the mothers use the HACA type of pump, which is the least expensive, the cheapest pump which is available in the market. So they go to the pharmacy asking for just an affordable pump. They give her the HACA type, and this is the worst type of pump that has ever been invented in the world, because it causes tissue damage, it causes breast tissue damage. So also the milk is contaminated because it is kept in the rubber part of the pump, no access to clean it. So this causes bacterial contamination. Also, it gives a faulty impression that there is no milk supply, because it is compressing mainly on the part of the areola that is not adequate, and we will talk about the appropriate choice of the pump today during our presentation. So this is one point, the faulty conception in the mother's mind about the amount of milk or about the way of expression, which makes her believe what the surroundings around her tell her, that she doesn't produce enough breast milk. So she chooses under pressure from this misconception to exclusively pump to be sure that she is giving enough breast milk. This is destroyed by the forward strategies that we have talked about, the faulty expression, the faulty choice of the pump. This leads to her that she believes she is not capable to breastfeed. actually the best result that she can have, as we have said, is to end the choosing exclusive pumping, but actually it ends that the mother finally ends to shift to formula, unfortunately. Facilitating someone else feeding the infant when the mother is returning to work, or a mother is busy with older children, or a mother have maybe some sort of trauma also, because we will talk about certain points here. Facilitating that he can take care of the baby, so she totally exclusively pump, and the milk is given to the baby. And usually the caregiver, usually even if this caregiver is the grandmother of the baby, it will be difficult for her, because feeding using the paste bottle feeding, or using the finger feeding, or whatever, or the drip drop method, which we will talk about today, all these methods will end that it is difficult, because the caregiver is old in age, is not the first priority or the first degree relationship with this baby, so he will not be keen how this milk is delivered, or even he doesn't have the full awareness of how the bottle can damage a way back to direct breastfeeding. So this is one point. Also, over 89% of the mothers who exclusively pump choose to exclusively pump only after unsuccessful attempts of direct breastfeeding. Mothers who never have a good latch with the baby. I have seen a lot of mothers through my life, maybe over 5,000 mothers along over 20 years. And I can't believe that these mothers they have difficulty to how to latch the baby directly. It is an instinct, however, it is a learned skill. It needs to be trained. The mother needs to be trained. And when we start earlier, however, I have also seen this in my clinic. When you start antenatal education with the mother, the difficulty that she have met, it's nearly diminished to at least the 10% of the mother who had never been taught during her antenatal period or during her pregnancy about the latch and the position. And the expectation also, the expectation that it is an easy way of breastfeeding, so, or even relating the breastfeeding to pain, she must have pain to be assured that the baby is transferring milk. All these are faulty misconceptions that you meet. I am sure that every one of you meets in her clinic also. Also, a case report of exclusively pumping family showed a client who attempted to directly breastfeed before every pumping session for 2 months before taking the decision to exclusively pump. Mothers reported feeling heartbroken or needing to cope with the grief of being unable to direct breastfeed, or transitioning to direct breastfeeding because she translate this that I'm a failure. And this is a very, very hard feeling that the mother can face, especially when we are talking about a period of baby blues, which can shift to postpartum depression, and it can worsen into psychosis if the mother is not dealt with an efficient counselor. We know that the IBCLC is not an ordinary healthcare provider. You have the detective eye of the clinician, you have the soul of the family counselor, you have the soul of the psychiatrist, so you are a multidisciplinary team in one profession. Also, we cannot talk about the exclusive pumping or the decision of exclusive pumping without talking about mothers who have been subjected during childhood or during also their period of adolescence or their older age of abuse. This is very common that the mother have trauma about this breast as sexual organ, so she feels traumatized when she put the baby directly to the breast. This also a condition that you may meet also in the clinic, and you need to talk to the mother in a way that touches her soul to reveal her feelings that she even cannot talk in front of other family members. So this is not to be missed. And when you need referral at this time to a psychiatrist, you must do it, because this is a very, very dangerous condition that can lead to more worse than the mother stop breastfeeding or choose to exclusively pump. Okay, mothers who return to work, as we have said, also before breastfeeding, the relationship is established. These mothers usually will take an ease and choose to exclusively pump. So these are different examples of why the mother choose to exclusively pump. Pumping may be also a way to increase the milk supply when nursing, and when the mother tries pumping, she finds it much more easier for her. And this is what I meet in the new era of mamas, which are, I know they are somewhat spoiled, not like my generation actually, because I'm approaching my 50s. So it's totally different about the mothers who are in their 20s. The new generation usually need to be, they don't need to have any struggles. They know they need the motherhood experience as a fluffy condition. I believe that you have met some sort of mothers like this, because I meet them a lot in these days. Believing that breast milk has numerous benefits for both the birthing parent and the infant, mothers who breastfeed had lower risks of breast carcinoma, ovarian carcinoma, type 2 diabetes. Children also who receive the breast milk either through the direct breastfeeding or the exclusively pumped breast milk have also lower comorbidities like otitis media, asthma, infection, obesity. We will not talk about the benefits of breast milk now, because it is a matter that's ended. We have no doubt of the benefits of breastfeeding to the mother or to the baby. Also, the preterm baby, as we have said, the babies who are admitted in the NICU, this will include the normal full-term babies who are just having a transient health problem, TTN, transient tachypnea of the newborn, or just respiratory instability, preterm babies who cannot latch, babies with cleft palate, babies who need to be separated for long stretch of time during the day due to work or illness of the mother. Also, I have seen research that have been raised lately, maybe in the late 2024 or the early 2025, talking about mothers who are admitted in the ICU for severe medical problem that they have faced. These mothers need support in the ICU. If we have trained personnel in the hospital, they can help the mother to express her breast milk. So I see that when we are talking about the baby-friendly hospitals or healthcare settings, there must be a hospital-grade pump in every hospital. This is the starting point. And the professional healthcare provider, he mustn't be an IBCC, but at least he know the basics of breastfeeding medicine, maybe the very, very basic skills that needs to help it needs to be gained by this healthcare provider to help the mother express her breast milk, know what is expression, know how the process of lactogenesis is initiated and maintained, and how to start new hormonal after delivery of the baby and the placenta, and how it continues autocrine, so evacuation of the breast is mandatory. All these are essential basics and pillars that must be present with every healthcare provider in every hospital, because in the hospital, the main setting of the hospital, even if it is not concerned with maternity and child health care, the ICU, how many mothers, how is the percentage of the patient who are admitted in the ICU? How is the percentage of mothers who are who have just delivered their baby or have a breastfeeding baby? If we have incidents or we have the ratios of these mothers, I think that it will not be less than 10% of the patients admitted to the ICU. So this needs skilled personnel. How can exclusive pumping support the milk supply? As I have just stated, the process of lactogenesis is a neurohormonal reflex, or a neurohormonal axis. So it starts neuronal and continues autocrine. The process of lactogenesis starts first after the delivery of the placenta and the delivery of the baby, and followed by the delivery of the placenta. We have the estrogen and the progesterone, which have the function of maintaining the pregnancy. They drop down, and when they drop, their inhibitory effect on the prolactin is released. So this inhibitory effect allows the prolactin to increase to the maximum. So at this point, the prolactin is at its highest level. We have this hormonal process continues for the first few days after delivery, then it shifts with the formation of the mature milk into an autocrine process. The brain got adapted to the amount of milk the mothers need. So this is crucial why we tell the mother, try to breastfeed the baby as much as you can, so that the body is programmed that he must produce maybe 450 milli, then 650, then established at 750 to 850 milli, which is needed by the baby at the breastfeeding period. So it is a state of evacuation of the breast continuously, the autocrine process. This takes us to the importance of exclusive pumping. Exclusive pumping must be the same way the baby should be fed. So when you tell the mother that took the decision that she will be exclusively pumping, you must tell her about this mechanism of breast milk production, how it goes and how, and this is a point also that I would like to make focus on or make highlight on it, which is the use of the galactagogues by the healthcare providers in the period after delivery. After delivery, what do you want from the prolactin if there is no pathological condition of the mother, or the mother doesn't pass through Sheehan syndrome, or doesn't have postpartum bleeding that leads to impairment of the blood supply to the pituitary? What do you want to, the prolactin is at its highest level because after release of the placenta, the estrogen and the progesterone drop, and usually the prolactin reaches its highest level. So galactagogues are of no value, and this is very crucial to be taught for every healthcare provider dealing with the breastfeeding diet. So what are the drawbacks of exclusive pumping? Usually the cleanup, because when exclusive pumping with the mother who choose to exclusively pump, there are a lot of extra pump and bottle parts to wash and sanitize. Not only does this add plenty of work to the mother, but it also takes a lot of time. Let down struggles. Sometimes the milk doesn't let down as quickly as much with a machine. So therefore, when I instruct a mother who have chosen to use the pump either exclusively or for some time during her journey, so starting by the hand massage and starting with the baby around the mother and starting even with few suckles of the baby will facilitate the work of the pump. Whatever the most efficient pump can work better when you start with the stimulation of the let down reflex with the hand expression or with the baby on the breast directly. So let down struggles can be overcome by this way. Let down, we have also studies which reveal the idea that when you start with the pump itself, the machine at the start, even if the machine is the most efficient, as I have said, and have a stimulation mode, it's not like the same amount of milk which is produced when a mother starts with direct breastfeeding or with the baby on the breast, or even with the hand massage till she find the flush of milk in front of her, and then she put a pump. So this is a very essential skill that need also to be taught for the healthcare providers dealing with the mother at this stage. The cost, and this is what I have been talking with Kara about at the start of the conversation. The costs of the pump, I know that you have always been, we are always up to date with everything that happen everywhere. So the cost of the pump have doubled. We have a lot of IBCLCs, our colleagues, they have an extra charge for the taxes applied for the pumps. It is nearly the double. However, in the last 3 years, the price of the pump have increased incredibly. So when a mother, even mothers who have chosen to exclusively pump and say that they want efficient pump, in this stage, you don't want a moderate power pump or a pump that is not that efficient. So you need to guide her to the best pump she can depend on for exclusive pumping. So when you tell her that the price of the pump starts, when an efficient pump starts from $400, $500, it's a huge number, a huge sum of money that not all families afford. So the cost of the pump, if it were a problem previously, in the coming days it will be a very, very hindering barrier because of the increasing cost and increasing taxes and disturbance all over the world about the cost of the pumps and any any machines or even the supplements. All things is increasing dramatically in prices. So what are the requirements for exclusive pumping? A choice of the right equipment. This is very crucial, as we have said. What is the, when we are talking about exclusive pumping, you need the most efficient motor. It's preferable to have a double pump rather than a single pump to save the mother time, because when she have single pump, she will need direct to use this single pump one side each time, and this will affect the best production of breast milk, or to apply this single pump one by one, and this will be very, very time consuming for a working mom or a mom who have older children. I think it is a barrier that will make her take the decision not to continue. So this must be clearly talked to the mother about these obstacles, so that she know that we can choose a single pump for the lower price, but you will pay for this from your time, the time you invest for your family or for your work or for all the children that you have. So double pump is best when we are choosing for exclusive pumping. Hospital grade, I know that it is not affordable for all mothers. It's far beyond the reach of mothers. It needs a place. So a place like maybe a hospital, and you have your own sets and go to, but who will do the exclusive pumping and go to a place to express her breast milk or to pump her breast milk every now and then in a hospital or a healthcare setting? It's far beyond the calculations of us as human. Okay, so when we give an advice for the mother, tailor the information as if you are in her own place, because what makes us different, that we are before that we are IBCLCs, we are healthcare providers, or even if you are a physician and an IBCLC, you are a mom. So apply this to your life and to your busy schedule with your children, and especially when we talk about mothers, most of the mothers nowadays are working mothers, even if they are working from home, but they are still having commitment, a long period of time of commitment to afford their living. So this must be considered. So tailor the information that you give to the mother, not just to give instructions that's not applicable. This is a crucial part in your success in the profession of the IBCLC, to know that this mother is a normal human being. She is not a superhero or a Batman that goes back to home with the pump and goes with a magical band and give everything just a point and it go settled. No, it's not like that. The mother have a lot of commitments, have her feelings. Usually the decision of going to exclusive pumping, even if the mother, if it's her own choice, but believe me, she has something in her heart that makes her cry, but even if she doesn't declare it, a very few percentage took the decision of exclusive pumping when with a happy feeling. Usually they have a sense of guilt that they were not capable to directly breastfeed, whatever the reason they have chosen to move to exclusive breastfeeding, to exclusive pumping, sorry. So the choice of the right pump is very, very crucial. You must make in consideration the exclusive pumping was chosen by the mother. Why? The socioeconomic status of this family, if there are older children that she support or not, or take care of, the type of work that she is committed with, even if it is from home remotely, you must talk about everything with her to reveal her feeling, to make the proper choice with her according to the price of the pump, according to the availability in the place she lives in, because we have different brands of the pumps and this differs from one country to another, and the taxes that will be applied to this pump. All this you must talk about with the mother frankly and teach her. Then we go to teach her how to deal with the pump, how to clean, how frequent should she clean the pump or sterilize the pump, and when the parts are not working efficiently, when to replace it, clarifying how to choose the proper size of the flange, and the manufacturer's website or the presence of the parts, the displaceable parts that needs to be changed every time. All these must be clarified for the mother in a clear way, so that she took the decision with you. It's not, we usually say that the IBCLCs are not decision makers, but we are educators. You educate the mother and help her to reach the best decision. So about choice of the proper pump, we have a simple test for as a healthcare provider, which is a comfy test. I believe that a lot of you know about this comfy test. But first, before going to the comfy test, we should talk about how to choose the pump flange size, or the flange, the right size. We have the size of the nipple is assessed from the base of the nipple, from its base to the tip of the nipple. And according to this size, you should adjust when it is according to the chart. From, if it is up to 17 milli, you can choose the 21 millimeter. Up to the 32, you can choose the 36 milli flange size. So most of the pumps should have the spare parts of the, or at least the standard size, which is a 24, and one small like the 21, and one large like the 36. But usually the manufacturers remove all the parts and leave one size, so that the mother should buy the other parts. This is not by the manufacturer, but by the seller. This is what happens according to the several experiences from several mothers. So mothers get shocked when they know that they should, there are other sizes. So this thing that she will know, never know if you don't clarify for her. Sometimes the mother tells you that the pump you have, you know that she is using a good brand pump. However, she tells you that she doesn't get much milk as you tell her about this brand or this type of pump. When you check with the mother, you find that it is not fitting well for her. The size of the flange is not fitting with the mother. So it's important to interpret when this flange is small, is appropriate in size to yield the largest milk production, or it is too large. The flange is too small when it is pushing the nipple into the tube or the tunnel of the flange. This is tight, and this will not allow appropriate milk production. The good fit is allowing the nipple with a little part of the areola. However, the too large, it allows a huge amount of the areola. This will not allow the negative suction pressure to work properly. So you know that the mechanism of breastfeeding, we will talk about the mechanism of breastfeeding also versus the bottle feeding. So at this point, you know that the breastfeeding depends on a complex of three things: the milk ejection reflex, which is under the effect of oxytocin, and the prolactin, which release the milk from the milk alveoli. Then the negative suction pressure, which needs a complete seal of the mouth of the baby, and in this example, we need the flange to make the action of the baby. So there is a complete seal, so that the negative suction pressure allows the milk to be pushed out from the milk ducts. When it is present in the milk ducts, it needs a suction power. This suction power will not be applied if the flange size is not fit appropriately, if it is too large and the areola is moving with a space, so there is no negative suction pressure to allow the extraction of the milk from the milk duct. So this will not allow proper, or the production of the needed amount of breast milk. Okay, so returning back to the comfy test, there are 5 major guidelines.
Dr. Soliman?
Yes.
I just want to give you a time check. We've got about 10 minutes or so before we open it up to questions. I know you have a lot left, so thank you.
Okay. So I have a lot to talk about still, but let's move to another point, because a comfy test is just to assure that the mother is fitting well with the pump. So we need to talk how the bottle feeding impairs direct breastfeeding. Using the bottle is interfere with the action we have just talked about. The mechanism of breastfeeding, we say that we need negatives. First, the contact of the baby or the suckling of the baby, the neurons which are present, the afferent neurons which is present in the tip of the nipple, hold these impulses to the brain, to the hypothalamus. The hypothalamus stimulates the anterior pituitary to produce the prolactin. The prolactin is stimulating the milk production from the milk alveoli. Then the oxytocin from the posterior pituitary stimulates the contraction, the milk ejection reflex, and we need the negative suction pressure. Here comes as the action of the baby, the negative suction pressure, which is created by the complete seal of the mouth of the baby over the areola, which is the place of the milk ducts, as we have said, about 30 millimeter inch away from the circle of the areola. Okay, at this point the baby suckles with the movement, the peristaltic movement of the tongue from front to back, At this moment this tongue is massaging the breast to get the milk out. So this is how breastfeeding works. Let us talk about the bottle. It's totally different. The baby, the tip of the nipple silicone or the teeth of the bottle is put in the mouth of the baby. So he usually closes or pressure with his gums, with the ridge of the hard palate on the tip of the silicone of the bottle. Okay, so the milk flow continuously. What makes it worse is that a lot of mothers that I see in the clinic usually widen the pores of the bottle teeth. Can you imagine it? So that it must increase the flow of milk. They are assuming that they are helping the baby with the flow. Can you imagine this? So the baby doesn't move the tongue, doesn't move anything except that he closes with his gums on the tip, and the milk flows in at least maybe the maximum 7 minutes. The 150 or 120 milli of bottle of the milk which is present in the bottle, either formula of breast milk, finish. Can you imagine the difference? So at this point, when we are talking a baby moving from bottle feeding to direct breastfeeding, we need to make this baby start moving the tongue again, start moving the peristaltic movement of the tongue, to know that to get milk, he must have this action of movement of the tongue to evacuate the breast milk. So if you have ever dealt with these cases before in your clinic, you will find that when you are trying to examine the suckling reflex of a baby who is bottle feeding, you will find that just when you put your finger in the ridge above in front of the ridge in the soft palate, okay, you find that the baby bites on your finger. He doesn't suck, he bites on your finger. So this is the impairment that the bottle does for the mechanism of breastfeeding. So he cannot make the action of breastfeeding. So this must be reverted. So when a mother takes the decision that she will be moving from the bottle, whatever the cause, she is exclusively pumping or have mixed feeding or whatever, she must first stop this bottle. The way that she gives the baby the milk is the first step. Okay, so I will move so the strategy to go from exclusive pumping to direct breastfeeding, you should instruct the mother first to practice a lot of skin to skin, to learn the proper latching position and the attachment. And we know that the position is how the mother holds the baby, how the mother holds her breast. The latch is the attachment of the baby to the areola, as we have said. And breastfeed before the baby gets hungry, because it is also a concept or a misconception among pediatricians actually and healthcare providers before the mothers. If you want to get your baby back to the breast, leave him without a feed for at least 4 hours to 8 hours, a stretch. I hear it a lot from pediatricians and healthcare providers who guide the mother, because this will make him very hungry, and when he will be hungry, he will take your breast better. Actually, this is not true. If you make this to the baby, he will have trauma about breastfeeding. He is severely hungry. He will never, even if you give the bottle, will never take the sufficient amount of milk. So you should calm the baby. You should shorten the period between each session of feeding, so as the baby is not that hungry before you introduce the breast. He is calm. He is relaxed. So he doesn't have a bad assumption about the experience of breastfeeding, okay? Because babies are very intelligent. Expressing some milk into the baby's mouth before feeding to encourage latching, and we will talk here about the drip drop method. The something that can help also using a nipple shield, because it have the same sensation of the silicone of the bottle, so we may deceive the baby about this, but the nipple shield depends on the age of the baby also, because not all babies will accept the nipple shield at a certain point, except when they are still younger than 3 months. After that, it is really difficult. There are other maneuvers or strategies that can help you better. So we can, first decision is to stop the bottle. We can use the cup feeding, the syringe feeding. This can be much better for feeding the baby with the bottle, to make a way for the breastfeeding directly to come back, okay? So we have also to help the baby sucking reflex to start stimulating the baby suckling by teaching the mother how to stimulate the suckling, where she put her finger, either with the help of, either if she do it without any aid of milk at this point, starting just to make the baby resume his suckling reflex, or with, then you can add a syringe, or you can add a feeding tube on your finger to allow the breast milk to flow in a way that makes him moves in the mechanism of breastfeeding, the peristaltic movement of the tongue, and to have little by little like the breast milk flows from the breast. So this is very crucial when you are taking a decision to go back to breastfeeding. So so we will talk also about the supplementary nursing system, and regarding the price, we know that the supplementary nursing system is a thing that you can make at home by using a bottle and using a feeding tube, and teach the mother how to make it at home, because the price can be a limiting factor when we talk about the supplementary nursing system if it is not affordable for her. So the way the flow of milk, depending on the baby's latched on the breast, and the tube flow is flowing the milk or is delivering milk to the baby without difficulty at the start of the transition, can help a lot in the idea of transitioning back to breastfeeding. The drip drop method also is amazing, actually, because the drip drop method helps the baby to have milk flowing in his mouth, because he is accustomed with the bottle. We know that, we have just said that the bottle gives a lot of milk to the baby without any effort or any peristaltic movement of the tongue. So when you start training the baby to suckle again by the finger feeding or by stimulating suckling, I have no stretch of time to talk about this in details, but maybe later we can talk about this. Then you can start stimulating the suckling of the baby again, and this will help the baby to move back to the breast with the SNS, with the drip drop method, with the nipple shield, the least option, which can be appropriate according to the age of the baby, as we have said. Indicators to stop pumping, to shift totally to direct breastfeeding. Acceptance of the baby for direct feeding at the breast. This is important limiting factor. Adequate weight gain after this transition, but you must also tell the mother that we may have a drop in the first week, or even the baby can be stable at weight in the first week of introduction, or at least give him at least from 1 week to 10 days. If the baby is not gaining weight, don't get panic, because this is very normal, and then follow up in the next following weeks. So this is very crucial. Satisfaction signs after breastfeeding, and the sense of fullness before the time of each breastfeeding. The normal growth also in the healthy infant, following the growth charts of the baby, is very crucial. So if the baby is in the 75th, the 50th centile, so you should find a baby which is the curve is moving forward, not dropping down, except after the transitional week or 10 days after this move from the exclusive pumping to direct breastfeeding. This is normal, so follow up with her later on. As babies return to direct breastfeeding, mothers have observed longer eye contact with their babies, which is amazing from the experience of breastfeeding I had also with my children. It's the most, happy thing that you can gain from the experience of breastfeeding. This smile you will never forget. calming and comfort for the mother and for the baby, decrease in being tense and upset for the baby, increase in the child's desire to be with them, increase in the child wanting cuddles, reduction of the pain for the baby, gentle actions in an older child who've even seen in younger babies, such as placing their fingers in their mother's mouth or stroking their mother's face. And this happens when the baby reaches 9 months or is crossing the first year of life. You have, if some of you have the experience of breastfeeding, you know how the baby plays with the mother's cheeks and nose and even push her nipples while breastfeeding as expression of, gratitude and love. So this leaves the most surge of oxytocin that you can receive, and serotonin, natural serotonin, which we all need. Increase loving feelings toward the child, a sense that they feel more connected to their child. This changes may occur before because breastfeeding is so intimate and repeated over time, and hormones acts on both the mother and the child to affect the feelings and actions. Thank you, Cara. I hope I have delivered most of the needed issues related to this topic.
Yes, thank you so much, Dr. Soliman. That was a lot of really great information. And we will send your PowerPoint slides out if that's okay with you. Some folks were asking to see those so they could see the ones that you had to move a little faster through. So we'll send that out. And we had a couple of questions come up. I need to get back to them here. You had mentioned how much colostrum that is expected to give to a newborn. Is there an amount that,
Yes.
What's the amount that you would recommend?
The amount of colostrum, it starts after delivery immediately from 5 to 7 milli per feed. This is the total amount per day is about from 38 to 40. The baby girl usually receive much more higher than baby boys. This is according to studies. So this is the total amount. However, what is instructed by healthcare providers usually give the baby 30 milli every 2 to 3 hours, which is far beyond the size of the stomach of the baby.
Okay, thank you. And Robin was also asking, you had mentioned that you described 20-year-olds as saying that they're experiencing motherhood with a particular condition. I'm not sure if you'll remember what you were referring to.
Yes, I have talked about this during the presentation. The mothers who had experience of child abuse or have been raped before, they have a struggle with direct breastfeeding. These mothers need to be counseled. If it is beyond our scope of practice as IBCLC, you should refer her. It is a must to refer her to a therapist or a psychologist to talk about this. So breastfeeding starts antenatally, because this will be revealed when you have sessions with her antenatal. Don't leave the problem till the mother deliver her baby.
Okay. Thank you very much for clarifying that. I'm going to put your contact info in the chat as well. Sorry, that second one didn't transfer. There's one more question I want to make sure you can answer. Is there an age limit where this transition is not possible anymore? Is when it's too late to train the baby to suckle and move the baby to breast again? Or would this be possible even for an exclusive pumper at 6 months old or more?
When the baby is exclusively pumping, but he is the mother of the baby, not an adopted child, because induced lactation is totally different. Okay, so when this is the own mother's baby, after 6 months, it is difficult, but it's accessible. I have this experience with my clients, with mothers who have breastfed maybe for 1 week or 2 weeks, and they took the decision to move at the age of 6 months, and they succeeded. But it needs a special type of mother. Okay, and it depends on the acceptance of the baby. So as I have said, counseling in the profession of IBCLC is tailored sessions. It's not theory for every mother that's applicable for each one. It's totally different according to the mother's her strength, her will. This is very limiting factor for me, and actually how the baby accept, because sometimes babies starting from 2 months, when they have the bottle, just to put him in the position of breastfeeding, they cry, they go cyanosed. they can stop breathing from the refusal, you know. So the idea of the acceptance of the baby is totally different. When we are talking about your own baby, it's easy up to 6 months. It's easy. It is not easy. It is an accessible experience at 6 months, but needs some effort from the mother. After 6 months, I find I didn't meet it a lot in my practice. I have not met 9 months returning back. No, I have not. Maybe she returns to the idea that she will relactate to continue exclusive pumping, but to take the decision that we be moving to direct breastfeeding at 9 months or more than 6 months, I think the acceptance of the baby is very difficult at this point, except at certain situation. If the mother had a pregnancy on top of lactation, the baby feels jealous and return back because he wants to resemble his brother or his sister.
Mhm. Wonderful. Thank you for answering that. Thank you so much for being here today, Dr. Soliman. I'm so glad it all worked out
Thank you.
smoothly. And
Thank
thank
you
you
so
for your
much.
patience and determination throughout that. And thank you everyone for joining.
Thank you so much. I was really happy to attend with you today and hope that I have transferred a little bit of experience that we need to have strengthen skills in. So thank you so much for this opportunity. I'm really happy, and really happy for your patience for me because of the disturbance of the internet connection the past week. I'm really sorry for that. Thank you so much.
Thank you all. Have a great rest of your day.
Thank you. You too.
Bye.
Thank you.